Good afternoon, everyone. My name is Jojo Zhang, and I will be your host for today's lecture. We thank you for joining us in a special summer edition of the Oxford SARS-CoV-2 lecture series. This is an online webinar series that features a wide variety of speakers from around the world who are at the forefront of COVID-19 research. Our objective for the webinars is to invite brilliant minds to give talks that are research-focused to promote learning, inspiration, innovation, and provoke conversations that will dictate the future of healthcare. Before we begin today's talk, I would like to introduce the organization hosting the talk and today's speaker, Dr. Moritz Kraemer. I would also like to address the process through which audience members may submit questions for Dr. Kraemer, which will be answered in the live Q&A session after his presentation. Today's talk is hosted by the Oxford University Personalized Medicine Society, a student and faculty-led organization dedicated to discussing current advancements in the field of precision healthcare and its impact on modern-day medicine. We would like to take a moment to thank our sponsor, the Oxford Center for Personalized Medicine, which is a partnership between the Wellcome Center for Human Genetics and St. Anne's College at the University of Oxford. Throughout the past year, we have collaborated to host several guest speaker events, as well as the first Oxford University Personalized Medicine Symposium. If you are a current student or affiliate of the university and are interested in joining our society for the upcoming academic year, please use the QR code to register. If you have any questions, please feel free to contact us at oxmed@ox.ac.uk. Today's lecture features Dr. Moritz Kraemer, who will be presenting a talk entitled The Effect of Human Mobility and Population Density on the Spread of COVID-19. Dr. Kraemer is a Branco Weiss Research Fellow in the Department of Zoology at the University of Oxford and an associate of the Oxford Martin Program on Pandemic Genomics. His work addresses questions related to the spatial spread of infectious diseases. In January, Dr. Kraemer began building a global line list database of confirmed COVID-19 cases, which has evolved into the Open COVID-19 Data Working Group, an initiative co-led by the University of Oxford, Harvard Medical School, Northeastern University, and the University of Washington. Using this data and other global data sets, Dr. Kraemer is focused on modeling the impact of human mobility on the spread of COVID-19 and identifying how human mobility data and genomic data can inform when lockdowns can be lifted. To submit questions for the live Q&A session at the conclusion of today's talk, please use the link and QR code, which will navigate to a Google form you can use to enter your question. If you would like to submit multiple questions, please use the form for multiple submissions. Now, without further ado, please welcome Dr. Moritz Kraemer. Thank you very much for your cooperation as we transition to his presentation.
All right, so this is the time when I have to share my screen.
Yes.
Right, let's do that. Can you all see that?
Yes.
Perfect. Yeah, thank you so much for that introduction. It was actually a very good summary of my research, which I feel I may adopt that once this presentation is over. So yeah, thanks everyone, and thank you especially for the invitation and to this seminar to provide some of the updated research we've been doing over the last few months. Thank you for all joining from around the world. And I'm very much looking forward to any of the questions you may have. And I want to say that even now that please feel free to contact me and others who've been involved in this research if you have any further questions even after this seminar. You can see my email here, and otherwise I'm sure you can find it somewhere online. So I'll be speaking about much of our early work on this outbreak, and some people may say like it's still early, and it is still early. And we're only 8 months into this, but sort of the work that we've been doing, especially in sort of January to April of this year, and then the potential implications that may have for potential vaccine rollouts going forward. So the talk is broadly structured in 4 parts. So I'll introduce kind of the work which was mentioned in the introduction around the open data repository of individual case counts. I've seen a couple of people who've joined in, who've participated in that, so I look forward and thank you very much for joining in. Then I'll be speaking about our directed research on the role of mobility in the spread of COVID in China, and also what implications that may have for epidemics around the world and potential questions about reopening. And then I'll be focusing into sort of an extension of that research to try to understand how sort of cities or crowding in general shapes epidemics and what that means for potential levels of attack rate of how many people have been infected and exposed in different geographic regions around the world. And then sort of frame this into the question, okay, well, as we are sort of progressing into a space where there is a potential for a vaccine. I don't have any news on this call, and I'm not involved in this work, but sort of as we're sort of transitioning to that space, what does that mean? What do these assessments from this research mean for potential rollouts for vaccination campaigns? So when we started very, very early on in January, to hear about this outbreak, we were very much interested in trying to identify detailed case data on this outbreak. And I don't know, many of you may have been involved in this research yourself on COVID-19. There was so much talk about market exposure. There was talk about human-to-human transmission. There were talks about like what is actually causing pathogen, causing this disease. And also, questions about potential risk of exportation through travel and trade and so forth. And I would just want to highlight 3 different types of data that are usually available in these emerging infectious disease outbreaks. And, we have worked in our group on the Zika epidemic, of course, in the Americas, but also on the Ebola West Africa outbreak and other outbreaks around the world, where we've worked with like a whole suite of different data sources. And one that we all see popping up in the news and everywhere around the world are aggregated case counts. So, if you want to check how many cases there were in a particular location, that's usually what you can find very, very quickly online. So, how many cases have been reported at each given location at each given date. And then there are clinical information. And I think, Peter Horby may have spoken on the seminar about sort of the work with regards to really, understanding the progression of a patient throughout their journey from being infected to becoming severely infected, and the different measurements that come into play there. And it's usually very small numbers in terms of like how many cases are actually recorded in that way on that clinical side, because not everyone obviously is hospitalized, that goes to hospital and goes to the ICU, for example. And then in the middle here highlighted is sort of the anonymized case count. So we usually in epidemiology refer to those as line list data. And line list data, you can imagine, are for each given patient, there's some sort of level of information in such data. So that could be the age of the patient, the sex, it could be different types of important dates, those dates being, potentially the date of symptom onset, the date of exposure to someone who's been infected, the date of confirmation, the date of first consultation with the doctor, and then also the time between the consultation and the actual date of becoming or like having a report back on the confirmation of disease. So the data, and I've mentioned a few of them that go into this process that we collected, are usually geolocated, so not on sort of the household level, but more sort of on a city level. So you can imagine, a case reported in Oxford would be entered as an Oxford case. And then, a crucial thing early in the epidemic was information about the travel history. So has someone been traveling either to China? Initially, of course, it was like Wuhan, then it was China, and then there were like these other hotspots, those in Europe being Italy, Spain, and others before the UK had a large epidemic. What we also try to do is really try to go in and check the data. So as they're being inputted into this database, they're being deduplicated, so we don't have multiple records from the same individual. So we have sort of that testing process of the data and the validation process being part of that. But then increasingly, as we sort of move through the epidemic, a lot of researchers asked us, okay, well, we want to have a bit more sort of context about the data, so understand a bit more about the data generating process. So we spent quite a lot of time finding out like how we could provide such sort of additional context information. And some of that was with respect to sort of the freshness. So like, when was the last time for a given country data was being entered? And other ones were like, what is the proportion of cases that actually have such detailed information from the overall number of cases that are being reported within a particular country? And the third one you could imagine would be related to, for example, testing data. So how many tests were available at each given time? And, like, through this process, of course, we've all learned a huge amount about data. And I think we all learned that no data is perfect, and like everything needs to be double checked, and there needs to be, like, we need to like find the context in which data is being reported. And especially as this sort of effort was one that was global, we were faced like with challenges around like, how much is data comparable between different locations. And, a prominent example, for example, would be Germany is testing a lot, and it tested a lot in the beginning of the epidemic, where other countries were testing very little. So how do we account for such biases, and how do we provide this additional context when we provide this type of data? And just sort of as a timeline of like how this project kind of emerged. So initially, I think it was early January, we had a few volunteers here in Oxford who were helping sort of to just tabulate this information from very unstructured data, really. So initially, the data in China was being reported by local governments, local health governments usually, but then there were also news reports. So like, we tried to sort of bring together these disparate data sources. And from that sort of initial data set that we sort of put together, which was around sort of, I think, mid-January, we had sort of a solid foundation of data we put together. We put like a very, very short blog post out, and this is actually in a blog post that's hugely for the communication of new results in phylogenomics and in virology. We kind of adopted it into that blog because it was well read by epidemiologists who were very interested in the origin of the outbreak at that time. So here on the bottom, you kind of see just a timeline of events, and each of those different different text here provides sort of actually only just the record of one particular case, and then the contextual information for those cases. For example, if they had any market exposure, travel history, contact with someone who reported infection, and also the demographics and so forth. At the same time, we put together sort of a documentation of the data collection process, just so that we had that documented, that other people could follow either that standardized form, but also knew kind of what that process really looked like, to sort of see how we can interpret such data in a research context. And I want to call out a few people here. I think Bo, Sabrina, Bernardo, these were people who initially spent day and night really in trying to sort of make this data most relevant and robust in that process, especially early in the outbreak. And I think that was, hugely valuable. And as we made the data openly available, that was very, very useful for other groups to then build their research on top of that, or at least have a resource of data already available to them that they could use in their process. So I want to really highlight that this data was always openly available and openly accessible for people to really use. And what we can also do with such data is then just visualize sort of the evolution of it. So here you can just see kind of from the initial sort of epicenter in Wuhan, like the rapid expansion across all provinces in China, and then the different pockets of transmission initially. I mean, sounds like a bit weird to say that now, because this is like only 8 months ago, but like, it obviously, we're a very different situation now than we were back in the time when we could really manage still the 50,000 cases we had entered into the database, and I think we're over 20 million now. And so through this process, we partnered with multiple groups around the world who were then using this data to really try to race to model, like, where is this disease going to go next, and like, how quickly is it going to be expanding across the world. So this is just, I think this was February 7th, so really only a month into knowing that this is like, there's something happening in Wuhan. There were people like starting to sort of model, okay, well, what's the progression of this? Like, what do we anticipate this to look like at the global scale? And how do we put together some sort of models that were previously run for, like, this is, I think, pandemic H1N1 model, to try to anticipate sort of the next move of the virus across the world. The data was then subsequently used very early on by multiple groups, and I want to just highlight a couple of them here. So on the top is a paper by Jeffrey Shaman in Science on, I think it was March 16th, was published to try to understand how much of the transmission that happened within China was undocumented. So, how many cases, for example, were too mild for people to go to the doctor, or even like the whole question around asymptomatic transmission, which at that point we had sort of some indication for, but it wasn't quite so clear, like whether it was asymptomatic or it was, pre-symptomatic transmission. So there was still a lot of discussion about that. But what they were able to do using the delay distributions from these detailed case count data was try to sort of benchmark their model so that they could make an assessment around, how many of the cases were actually mild and, maybe asymptomatic, so that they wouldn't be recorded within the health system. Also, Matteo Cinozzi and Elsa Spignani, a group out of Northeastern University, used these data to try to better understand the global progression of it. So this is like an agent-based, network-based model that uses epidemiological data to initiate simulations to where the disease may spread next, using travel data and a lot of other information about demographics. They were able to use the delay distribution between symptom onset to confirmation to try to benchmark their model so that they can initiate their simulation. So we're quite happy to have these two major papers use these data for these purposes. And then similarly, there was a big question, of course, around the incubation period, which is the period between infection and symptom onset. And this data was, because it had travel history information, we were able to sort of make a robust assessment of the incubation period, and it was subsequently published by Stephen Lau and Justin Leslie's group out of Johns Hopkins. And these are just a few highlights of the papers that came out sort of between really early March and late April to try to find a way to assess sort of very basic features about the epidemic. Of course, you can imagine, as we're sort of moving into a space where so many cases now, that we aren't really able to keep up the process of like ingesting this data manually into a database. So with that consortium that we've built around the data, which now really has grown to like multiple institutions and like a lot of people who are still involved in the process, we've tried to sort of build an infrastructure that is more sustainable, not just sustainable for this outbreak, but also sustainable for future outbreaks. And within that, there's multiple different processes involved. Some of them are related to making it easier and reducing the risk of false entries into a form rather than an actual spreadsheet. This is just a screenshot of how that looks like, and this is very adaptable, and like we hope to be able to scale this also past this outbreak, and will be openly accessible, of course, as we are sort of launching it. Similarly, there are now across the world about 47 to 60 sources, or like not sources, but countries that report detailed structured line list data openly. Obviously, they are like reported in different types of formats. So the attempt here is that we can automate that ingestion process into the database, and by doing so, also standardizing across these different data sets so they become more valuable as we are trying to compare different countries to each other. And then that should be facilitated by the ability to download this data straight into other sort of computer platforms of other research groups, for example, who may want to use such data for their assessments. I know that, for example, in the United States, the real-time estimation at a state level of the reproduction number, for example, uses some of the delay distributions between onset and confirmation and reporting. And I think similarly, some people at the London School of Hygiene and Tropical Medicine have been using some of that information to make more rapid and better assessments of the reproduction number in real time, which in many ways has been used make policy across the world. And we can debate, of course, whether that's the right metric, but it's surely one that's being used very successfully. But I want to dive into a little bit of the research that we have done, not just the data collection. So I like showing this slide because I think it kind of well illustrates kind of how much more connected we are today than we used to be sort of in the 19th century. So on the top right here, you see the travel times from London across the world during that time. So this is a map from Francis Galton. And you may not be able to see this on your screens, but green would be within 10 days, all the way to brown, which would be more than 40 days of travel. And this is the time it takes from London to travel to those different localities. So what you can see, I think, very, very quickly is it would take you much, much longer to travel to places, which, of course, in turn, would then also reduce the time, or like increase the time of an arrival of a new pathogen emerging in a disparate geographic location. That has obviously changed, and we've all been sort of experiencing that change over the last 10, 15, 20 years, really. So on the bottom, you see just screenshots of how many flights are, like how many planes actually in the air and any given moment in China on January 23rd. Is just a screenshot of that. So this is before the lockdown was implemented in Wuhan and across the country. There were about like 12,000 flights in the air at that point. So heavily connected cities across China, and like obviously also across the world. And what you see on the right-hand side is sort of the evolution of that flight network as you were sort of moving into the period of mid-February, and there were only like 1,600 flights in the air. And sort of we tried to sort of work our way through understanding the role of mobility in sort of spreading the disease from its epicenter in Wuhan across the country. So what you see on the left is just the evolution of the epidemic, so just the numbers of cases. And I mean, and a few key sort of highlights there. So one is the implementation of the lockdown of Wuhan on January 23rd, and then sort of in red highlighted the incubation period window since the shutdown. So this is like kind of from time of infection to showing symptoms, that period of about 5 days later. And what you see on the right-hand side, I mean, and I think maybe to mention here is also like the huge epidemic in Wuhan obviously was much bigger than it's just shown. It's just based on the case counts, and then the small epidemics in all the other different states or provinces, sorry, in and around China. And what you see on the right-hand side is based on the information that we had available through this data collection process, is the information on like the individuals who had travel history to Wuhan. So you can see here each of those arrows represents an actual individual moving between Wuhan and another location. And you can quickly see kind of like the central importance really of Wuhan in its travel network across the country. And then you can see kind of also the timing of when these individuals have actually moved between these places. So the color scaling showing kind of like whether this was like the day before the lockdown was implemented, or like sort of weeks before that, really. And from that, you know, the hypothesis really was, you know, like how the question that arose very, very quickly is, you know, is transmission now widespread within the country, or is there still a chance to control the epidemic by implementing such rigid measures of travel restrictions from a particular location? So the top panel here showing just the evolution of the movements from Wuhan to all other places across China, and you can see like through the implementation of the lockdown on the January 23rd, a quick and rapid drop really of the movements within China. And this is something we of course at this point know, but like it was really down to like almost no movements out of the city. And there's been debates about sudden increases of movements right before the lockdown was implemented, but we anticipate still that these are movements that are related to the Lunar New Year of people visiting their families. But then you can see the distribution geographically, where are these movements going, and you can see mostly concentrated around the eastern coastal cities of China, the big cities, the mega cities, especially sort of on the southern side, Guangdong province, but also Shanghai, Beijing, and that central sort of mobility network that Wuhan was connected to through trains and highways. And what you see on the bottom is the correlation structure between the epidemic in Wuhan and the epidemics outside Wuhan. So just looking at that curve, so you see kind of just by sort of taking the cases and the movements from Wuhan, they're extremely correlated to the epidemics that happen in other provinces across the country, indicating really the predictability of human mobility in understanding where these new epidemics really occur outside the city. I'd like to highlight on this slide kind of the sort of evolution of sort of the transmission patterns within China. So on the bottom left here, and this is a paper by colleagues in Guangdong province, it sort of disaggregates the epidemic curve for imported infections from other provinces, and then local infections recorded in Guangdong province. And those are mainly identified through contact tracing, family members of people who have had travel history or community testing that was performed. And this is extremely detailed data that was available through that collaboration in Guangdong. And what you can see here, and I think that's one thing we found very interesting, was that there were of course before the implementation of the lockdown, a lot of imported infections from Wuhan, and those sort of were sort of peaking almost 5 to 6 days after that. So really the incubation period after a period of being infected and showing symptoms. And at that point, there was a lot of the control efforts were still focused on sort of those that have had actually symptoms. And then on the bottom in the green, you see kind of the trickling local infections being recorded. And so what that illustrates is kind of that the local epidemics actually never really took off. So the local epidemics, even though there were sort of local cases transmitted, it didn't shape sort of the epidemic curve in a classical sense where it sort of goes up and down. So illustrating that there was more cryptic transmission, but also transmission that just trickled along really to maybe family members or others in that process of generating sort of that local epidemic. And sort of that sort of illustrates just sort of the shift perhaps of the control measures with regards to the implementation of travel restrictions to local contact tracing, and also the ability in sort of closing venues and so forth to locally suppress an epidemic, which, if any one of you have ever been to Guangdong province or the sort of mega city of the Pearl River Delta, it's highly connected, it's extremely high population density, so you would be assuming to have a local epidemic to take off there in that process when the cases are being imported. But the measures taken there really, as a combination of the restrictions and the local measures, seem to have been extremely influential in bringing that epidemic under control and not having a local epidemic take off in a large fashion. The other interesting thing that we found in that process of analyzing the demographic data, when I say demographic data, for each individual case, you have information about the age and sex. We're trying to contrast sort of whether, or would hypothesizing that there was certain differences between the period of travel-related infections to those related to local transmission. So what you can see kind of here on the right-hand side of the panel is for two different time points, sort of the time before the lockdown and then the subsequent incubation period after, and then the period after that. Sort of what were the sort of characteristics of the individuals that were reported with disease. And interestingly, sort of in the beginning of the outbreak, a lot of the individuals that reported reported infection, or at least were reported with PCR confirmed infection, were sort of younger males, so males in the ages between like 42, 41. And that stayed sort of the same for those with, travel-related infections. But interestingly, sort of in that later period, those individuals actually became older and much more related to sort of the underlying population structure of the population outside of Wuhan. So the hypothesis really was that there was sort of a transition, at least, from travel-related infections to local infections over that period after the cordon sanitaire was implemented in Wuhan. However, those were then brought under control by other measures that were maybe not as related to those travel restrictions. So this is the type of power that sort of demographic data may have in illustrating sort of shifts in the sort of demographic structure of the cases that are being observed. And, you may remember this from some of the news reports now. Of course, you can see that in parts of the United States, that more younger individuals drive the epidemic. We see less hospitalizations per infection, maybe due to testing as well. But there's sort of like transitions and dynamics that exist in sort of the age patterns of who's reporting infections. And of course, these are incredibly crucial questions also when we think about the upcoming time when schools are reopening, and like, who do we think are the most people at risk of becoming infected? Is it the sort of, people, the parents, and then the children? So we see those two age groups popping up as those with high numbers of infections, or is it sort of more widespread within the community? So these are the types of questions that can be investigated in that process of analyzing such population level demographic information through time. But now I want to briefly transition to like sort of, once we see infections to pop up in cities across the world, like what are the structures of these epidemics in these particular different cities? And the main motivation really here is try to get at a mechanism to understand what drives higher population attack rates geographically across different areas. And many of you, I don't know how many of you are from the UK, but you'd be aware of like differential attack rates in London compared to other places around the UK. And what is that really related to? Is it the numbers of introductions, or is it to London versus other parts of the country, or is it the possibility for onward transmission given some sort of structure of the population, which is related potentially to population density and other factors? So there was a paper in 2018 discussing this in the context of influenza in the United States, which was quite influential in like us sort of generating the hypothesis around sort of crowding, so how many neighbors you have and how how likely you are to come in contact with them, driving sort of the different shapes of these epidemics in different cities. And what you can see here kind of on the bottom left panel is the correlation between the shape of an epidemic and the final kind of attack rate. So, like the more peaked an epidemic is, the shorter it may be. Maybe the peak is higher, but you get like less people infected, whereas you have potentially more drawn out epidemics, which take over a longer period of time, are harder to sort of get rid of. But what are the mechanisms to really underlie that process? So we went in just with a sort of simulation approach to try to sort of get at that mechanism a little bit more, to try to say, well, we have different subpopulations that are structured hierarchically across these cities. And obviously that changes a little bit as we're sort of moving through periods of travel restrictions and so forth. However, there are like places where you are just much more likely to come in contact with other household members. You can think about this at different types of scales. So some of that may be related to households, some others could be neighborhoods. and others. So if you imagine London, New York City, and other places, there you have like between neighborhood transmissions, you have within neighborhood transmissions, and all of those have different sort of transmission rates. So on the top right is just like sort of illustrating for two types of networks, one more sparse network and more crowded network, how likely it is that you get infections to be reported within each of those different networks, and the blue indicating here places where there was reported transmissions. And you can already see that in sparse networks, the likelihood of sort of onward transmission is much reduced, given the smaller likelihood of coming in contact with others. And how that then plays out into epidemics and the shape of these epidemics is illustrated kind of in figure panels C and D here. So for those sparse networks, what you're usually getting is kind of a quick peak and then a quick decline of the epidemic that changes a little bit as you think about sort of particular interventions being put in place during those times. But then as you're sort of moving over to those crowded networks, those epidemics actually look much different. So in gray here showing the sort of median of those simulated epidemics, and you can already see kind of there are much more drawn out epidemics in these crowded networks. And those also usually have higher final sizes, which then indicates, like more people have been infected in these places in general. But then there will still be remaining pockets, of course, the transmission hasn't yet fully occurred. And then we can use those fitted models, and I didn't put the regression here for some reason, but we like sort of look at that in Italy and China to try to sort of understand how crowding and population density affects those types of shapes of these epidemics, and which are highly predictive of them, by simultaneously accounting for the importation process. And then using these fitted models, we were trying to sort of illustrate, so well, like given certain assumptions, how does that peakedness of an epidemic shift across the world? So where would we be potentially expecting longer and more drawn out epidemics, even under scenarios of different types of interventions? And this is just getting at a sort of starting point of like illustrating the spatial dynamics of these infectious diseases at a local and sort of a connected side, and then sort of what that potentially means when we are thinking about vaccine deployment and so forth. So just giving a quick outlook here, or maybe also a quick summary of like what we've been finding. So one is just that this open detailed epidemiological data can be incredibly helpful for other groups, for groups around the world, to really be used to get at some of the basic features of an epidemic. And also through the open nature of it, it is like quickly being adopted and used. We do know this, and this is intuitive, that mobility really shapes the spread of COVID-19, and it's almost like a textbook example of it. So even though we've studied it for a long time, we never believed it would be, playing out in nature in that way. So it was highly predictive, really, of the spread of the infection. But we also find that, like local factors, really like crowding and early invasion of a pathogen, may really shape the number of people who then have been eventually infected by it. And, those two things in tandem and like working those things out together, and we can't really do serosurveys across the world everywhere. We're hoping to sort of use those now as we're sort of looking at the mobility networks shifting again back to sort of potentially something how they were before, what that really means when we think about the vaccine deployment. So the basic question there that arises would be, what are the spatial locations really that are most, when you deliver vaccine to those places, they're most effective in curbing the epidemic or providing protection against at the population level against infection. But I'll end it here, and I hope to answer some of your questions now that in the discussion.
Great. Thank you very much, Dr. Kraemer, for a very engaging talk. Yes, we do have some questions for you, so I'll just go straight into that. So the first question we have is, given human mobility and population density as crucial factors, does the spread of COVID-19, Is the spread of COVID-19 higher in megacities as compared to rural and countryside areas?
Yeah, it's a very good question. I guess like something that I want to touch on at the end of the presentation. So, in general, I think there was some simulation studies in the beginning. In general, we would assume, based on basic theory, that the places who got the disease early, where it took longer for potential interventions to come into place, are usually the places that are mostly connected. So those are the places that have higher population sizes. And then within those places, there's a higher chance for people to come into contact to then have, that the disease spreads further into the population, which would indicate higher population attack rates. However, that really depends on where you're looking. So even across Europe, we see like wildly different, levels of attack rates really across the different countries, which mainly has to do potentially with those factors. A couple of studies here. So one from Spain, where it was shown that Madrid and the surrounding areas of Madrid were much heavier affected than others. That may have to do with such processes. And similarly, London being more affected than many rural areas across the country. And similarly in the United States, for example, New York City, having been affected early and having been affected very heavily in the beginning, has a much higher attack rate than many rural areas. But of course, like as you know, this depends on many, many different factors, including the types of restrictions put in place, and they may now be released in some places in more rural areas, which then puts an additional burden on those populations. So it really is something that needs to be taken into account, but like a lot of more work needs to be done to like sort of, I guess, ultimately validate all of these more modeling-based studies.
Great, thank you for your answer. So our next question is, during the early stages of the pandemic, so late February to early March, did the UK governments underestimate the sources of infection from the EU?
Yeah, so I think, it's always a critical sort of, more politicized question at this point. I think what is fair to say is that the places that locked down earlier, and not particularly happy using that term, but the places that put non-pharmaceutical interventions earlier have been able to control the epidemic much more effectively. Those places, the classical ones are New Zealand, others are South Korea, who have done an incredible job in ramping up testing quickly to identify individuals that have been infected and exposed and potentially had contact with others, and that those measures have been incredibly influential in bringing the epidemics under control in some places. In the UK, specifically at the time when there were already large epidemics across many different locations in Europe, there was evidence for local transmission in the UK, and I think with a few weeks of an intervention that happened earlier, there would have been ultimately the ability to reduce transmission in the UK.
Great, thank you. So the next question we have is, was the London Underground a key factor in the rapid rise of infection in London in early March, much of which went undetected?
Yeah, it's a good question. I haven't investigated that myself, and I think there's been a lot of debate about, the actual risk of transmission in transports. We do have studies that particularly bus drivers in the UK and especially in London have been affected quite heavily, especially because they potentially have been exposed much more to virus in that close contact over prolonged periods of time. There's been some evidence for transmission to happen in trains in China, but there's a very small sample, and it's very, very hard to give a definite answer to this. I think what is fair to say is that when there were hotspots of transmission in some places across London, and people were traveling heavily between that place and others, they could have introduced transmission to these new localities. Whether that transmission had occurred in the transport network, like i.e. the tube, versus the actual workplace or restaurants or bars or nightclubs, I think needs to be further investigated. I do, however, think that this disease spreads, and this is my opinion, and I think that it spreads especially in places where there's prolonged contact between individuals infected and infectious.
Great, thank you. So the next question is, there's been evidence suggesting that COVID-19 cases were present outside of China in as early as December of 2019. So what information in your line list database would help address the origins of these very early cases?
Yeah, super good question. I mean, I actually haven't heard of those reports in detail. I haven't at least read them in detail, those reports from earlier transmission events. I think like one aspect that was incredibly useful in our database early on was sort of differentiating between cases that had this market exposure versus not market exposure. I think there's still debate about whether that was the first super spreading event in the market or whether there was actually the spillover event in the market. So I think there's still a lot of unknowns there. I think it would be interesting in general to contrast some of these reports and the demographic information, for example, of such reports to the early reported cases from China and see whether there were any sort of similarities there. And I think it's reasonable to assume that the transmission events, the earliest ones, were really in late last year rather than beginning of this year.
Thank you for your answer. So the next question we have is, was there anything that surprised you from how the reality of the epidemic differed from what you expected from models and predictions that had been made? And if so, what were they?
Good question. I'd like to hear who asked that question. I think the aspect that in our group was one that we continuously, not surprised, but maybe like really want to get a better handle on, is like the impact of the continued importation process of infections. So classically in epidemiological models, we're assuming very much that once a critical number of infections have occurred in a new location, that there's sort of self-sustained transmission within that location, and any additional seeding event may not be as relevant in driving the epidemic dynamics. However, what we can see very clearly, I think, for this disease is that human movements are, first of all, extremely predictive of where the outbreak is going, but also that we see the importance of human mobility through time to be relevant. So really disentangling whether that is based on the continued importation process or local transmission. I think like working that out more fundamentally, I think, is an incredibly interesting question that I think the community in general is trying to answer, but I think that is something that we really want to get a better handle on.
Great, thank you. So our next question is, it appears that over the past several months, the pandemic has transitioned into younger adults. Do you believe this has presented a false sense of control over the pandemic when in reality, it has simply transitioned into younger and healthier adults that are more likely to survive if they contract COVID-19?
Yeah, I think there are a lot of issues with that. So, I haven't followed that aspect in too much detail, but we also we shouldn't forget that we have a lot more availability of testing. So, where previously only symptomatic individuals could get tested if they had exposure to someone, or when they had really severe disease that they could get tested. There's a whole sort of evolution of like who's getting tested where and how. And I think, there were probably a lot of younger individuals that were infected early in the epidemic, and that was just not being recorded necessarily because they were primarily mild infections, or there wasn't the availability of testing really for those individuals, and it was much more concentrated towards the older age groups. And now there's, of course, a lot of reports of young individuals becoming increasingly more affected because of like higher levels of exposure. And, you know, we shouldn't neglect that there is certainly a learning process. People are more careful, more sheltering, more people are isolating, more who are in these risk groups. But I completely agree with the question. It is providing a false sense of security that that young people, you know, primarily get mild infections, which we have to remember that I think we're only 8 months in here, and, you know, more chronic or severe infections at a later point can definitely occur in young individuals. And even though some of these reports are more anecdotal, I think more and more studies will come out in that space. But I'm not a clinician myself, so I'm not looking at that in detail. So I agree. Like, this is, we're far from done here, and I think there's huge risk of resurgence across the United Kingdom and into many other populations that have seemingly controlled the first wave of the epidemic at this point. And we see that already happening in many parts of Europe.
Right, thank you. So our final question is, if an effective COVID-19 vaccine were to be available today, based on epidemiological models, who do you believe should be the first to receive the vaccine to most effectively control the pandemic?
So, very good question. I think very complex. There are two, I think, important aspects to remember. One is sort of, which are the individuals that should be receiving the vaccine so that severe infections can be mostly reduced. And that mainly is based on comorbidities and age. So I think there's sort of an aspect that needs to be considered in that space. So that is heavily targeted towards an understanding of like how many infections can we avoid in these population groups. Then there's sort of the question around which are the age groups which are essential to our society. So people who either essential workers, people who work in hospitals, nurses, those that cannot take the time to isolate, that have to go to work. And I think there's a huge need for prioritizing those individuals, especially as they're sort of adversely otherwise being exposed to disease and risk. And then there's the spatial aspect that I'm more focused on, which I think I can speak more to, which is around like where, and you can imagine it as sort of a contact network. In that contact network, should we be deploying vaccinations or controlling the epidemic so that there are trickle-down effects into other regions that are heavily connected to that place? So just one example of ongoing work we have right now is in Mexico, where we're trying to look at sort of the concentration of Mexico City with regards to its connectivity to other states and municipalities across the country, and simulating based on that and estimates of population level attack rates, if you were to vaccinate, which are the spatial locations that would be most effective in. But I think those three considerations are just a few of those to outline with regards to how to prioritize best.
Great. Well, thank you very much, Dr. Kraemer, for taking the time to present your research and answer our questions today. Before we finish, I would just like to take a moment to thank our sponsor, the Center for Personalized Medicine, the Wellcome Center for Human Genetics, and St. Anne's College for sponsoring today's talk. To view this lecture at a later date, as well as some of our other lectures, please visit the Center for Personalized Medicine website or scan the QR code provided. We hope you have found Dr. Kraemer's talk informative, and we wish you all the best. So thank you once again, Dr. Kraemer, and thank you very much to our audiences. Take care, everyone.
Thanks very much. Bye.
Bye.